Good afternoon, everybody. I'm Lee Storrow, Policy Director at Community Education Group. We're a nonprofit working on combating the syndemic of HIV, viral hepatitis, and substance use in Appalachia. I am here recording some introductory remarks with Regina LaBelle. Regina is at the O'Neill Institute in Georgetown and the former director of the Office on Drug Control Policy, to kickstart the conversation we're having at the West Virginia Rural Health Association's conference about methadone access. Regina, would you mind just giving a bit of an introduction and explaining your interest in drug control policy?
Sure, thanks. So glad to be here. I'm sorry I can't be there in person, but thanks so much for coming to Georgetown. As you said, we're at the O'Neill Institute and at Georgetown Law Center. So I have been here about on and off for almost 4 years. I work at the intersection of health law and policy. And I served in the Biden administration and the Obama administration in the Office of National Drug Control Policy, which sets the drug control strategy for the nation. Last year, I spent from January until November as the acting director of the Office of National Drug Control Policy. Thanks for having me.
So again, we're talking about methadone and specifically methadone access in West Virginia. I just want to kick off with the question, there's a lot of stigma that exists around methadone as a tool. Why do you think there's so much stigma around methadone?
Well, I think there's stigma attached to people who use drugs generally, and there's certainly a lot of stigma attached to forms of treatment that involve medications. Even if you think about, standing in line at a methadone center to get treatment, this is not how we treat people with other forms of illness. And so it's been, long baked into our addiction policy. And the way we treat people with addiction is almost as if we shame them enough, they're going to get better. And we know that that's not the case. But we also know that methadone is kind of the case in point where we use stigma to shame and blame people with addiction.
Yeah, absolutely. So, you certainly know this well. I think some folks in the audience do as well. So there are 3 forms of MAT. And I sometimes hear from community members that buprenorphine and naltrexone, that those 2 provide sufficient options for folks. That methadone, this third option, maybe is just a little too much, right? That we should focus on these other 2. Can you just talk a bit about those 3 different forms of MAT if I'm someone who's new to this conversation, and talk a bit about why, methadone is an important tool for patients and providers to have at their disposal?
Sure, thanks. So there are many roads to recovery. We know people who, have used all 3 forms of treatment. What we need to do is make sure that the treatment, the medication, fits that person's needs. For some people, naltrexone, which is not the same as methadone or buprenorphine, that's okay for them. For someone else, buprenorphine, which can be administered by a doctor, that is suitable for them. And in other cases, methadone is what's best for them. So really what we need to do is not have law and regulation kind of dictate what treatment individuals need. But it needs to go, and I'm saying this as an attorney, we need to go from a legal and regulatory approach to this issue to more of a public health approach, to meet people where they are and get them the types of medication that they need to live a full life.
Yeah. So you're, very familiar with some of the national work around drug control policy. 2022 National Drug Control Policy Strategy was released a couple months ago, and it includes several recommendations to make methadone more accessible. As someone who's a big methadone access advocate myself, I was thrilled to see that and see some of the recommendations come out. Can you talk about what some of those recommendations are and how lifting the methadone moratorium in West Virginia would be consistent with the goals in that strategy?
Sure. So, your native son, Dr. Gupta, has done an incredible amount of work at the national level to make sure that individuals know how we need to meet people where they are, to put harm reduction front and center, but also to make sure that all 3 forms of medications for opioid use disorder are accessible. States govern the practice of medicine. We know that there's a lot of flexibility in states, but we also know that there are over 100,000 people dying every year and many of whom because they're not able to access the medication that would be best for them. And so lifting the methadone moratorium in West Virginia is one way that we can decrease overdose deaths in this country.
Yeah. We chatted a bit, thinking about the national landscape, right? That there's different policies in place in all 50 states. Do you have a sense? West Virginia's moratorium was passed more than a decade ago. There's currently 9 providers who were already providing in the state before the moratorium was put in place. So, from my perspective at Community Education Group as an advocate, we're glad those 9 providers are there. We do think there needs to be more. Is having a moratorium in place for methadone access specifically, is that common in terms of a legal approach around the country?
No, it's fairly unusual, and there are only, there are very few states that have this type of moratorium. I read an article a couple weeks ago about the amount of time it takes someone in West Virginia to drive to access methadone. I mean, if we wanted to build a system, develop a system that put up barriers that keep people from getting healthy, that's what a moratorium does. And we need to make it easier for someone to get the type of evidence-based treatment, as opposed to make that easier than get using your drug of choice or and entering recovery.
Yeah. And just to make sure folks understand this, if I am using methadone as a tool to quit using drugs, I have to get that every single day, correct? So if I'm somebody who's lives more than an hour away from a clinic, that barrier is pretty substantial.
Yeah, I mean, again, it's for anyone who's had a substance use disorder, those steps that you need to take to enter long-term recovery, that's where the barriers need to come down. And one of those barriers, a significant barrier, is obviously transportation. So if, that could be what they did during COVID was make it easier for people so they didn't have to travel, they didn't have to wait in those lines, they could have a take-home supply of methadone. And what did we see during that time? We didn't see an increase in diversion. We saw that actually allowing people to have take-home methadone worked. And so we need to extend that past COVID-19 public health emergency.
Yeah. So I've done substantial work over the last year, talking with policymakers about this topic, bringing folks together. And my experience has been that particularly because of the opioid epidemic and its impact in states like West Virginia and the Appalachian region as a whole, we have this moment in time when policymakers who kind of favor an abstinence approach, who might take a more conservative approach to drug policy, who a couple years ago kind of might have brushed off an idea of increasing methadone access, they're really open to conversations, although probably still need to be brought along. What's your thought to advocates thinking about strategy, thinking about talking points, about somebody who's open to talking with us about this topic, but's maybe a little skeptical?
Well, I think we need to make sure we're, on all levels of drug policy, we're meeting people where they are. I mean, that's true in the harm reduction process, but it's also true in advocacy. So what is it that, that individual needs to hear so it's a medication. Some people have to stay on it for a lifetime. Other people don't. But it's all about getting people in a healthier place so that they can live fulfilled lives in recovery. And that's what access to methadone can do for a lot of people.
Yeah. So we've got an opportunity to chat with you to get some thoughts for a couple minutes. Stepping back just from the methadone issue, what are some of your hopes as we think about evidence-based drug policy? There feels like we are at a moment in time that there's real opportunity. We're also about to see, tens of millions, hundreds of millions of dollars coming into states like West Virginia because of the opioid settlement to do new funding, new grants, new opportunities. What are your hopes for where we might go when we think about evidence-based policy to reduce overdose deaths?
So the great point about the opioid litigation dollars. We have a public health emergency. And part of this public health emergency, we don't have enough workforce in this country, particularly in rural areas. We just don't have enough people for peer supports, for treatment. for prevention. All elements of addiction policy, we really need to invest in workforce. So that's one thing that I really hope is done with some of the opioid litigation spending. The other piece that I think is really important is opioid litigation funds are going to be over almost 2 decades. That money is going to continue to go to states. So we need to make sure this isn't a 1-year process, isn't a 2-year process. Keep your eye on the ball as to where that funding is going. We develop model legislation at O'Neill for establishing individual individual funds sources so that you can monitor where the funding is going and make sure that it's not diverted to things like they did in tobacco litigation. So it's spent on reducing overdose deaths and making public health a priority.
Awesome. And I want to end just on a bit of a fun question. So, you got to work in the Biden administration at the very start in 2020 after the election. Can you just talk a bit about what it was like to work in that administration and to head the Office on Drug Control Policy?
Yeah, so it's an honor of a lifetime to serve at any public for any public official. As I mentioned, I worked in for city government, and I served in the Obama administration and the Biden administration. I felt it was really, really important to serve, to answer that call to service. Anytime anyone has that opportunity. I am I'm the youngest of 9. I grew up on a farm in New England. So the first time I went to the White House was when I worked in the White House. So it's an honor, and it's not something that I ever thought I could ever imagine doing. But the opportunity to serve and to make a difference on this issue in particular is really incredible for me.
Well, Regina, thank you so much. We value your time, and we value the role you've helped in supporting the work that's happening in West Virginia. I really do believe those of us working on this policy have a really exciting opportunity to increase access to methadone and, at the end of the day, save lives of West Virginia residents, which is the reason we're all here and all committed to this work.